So this is a 70-year-old female with past medical history significant for diabetes. The patient developed rectal bleeding approximately 3 years ago. This led to further workup, including a colonoscopy. The colonoscopy showed a sigmoid tumor, and this was biopsied showing adenocarcinoma. The patient had further workup, including CT scans of the chest, abdomen, and pelvis, and the CAT scans showed multiple metastatic lesions in the lung and in the liver. A biopsy of one of the metastatic lesions in the liver showed an adenocarcinoma consistent with colorectal cancer. Molecular profiling confirmed that this tumor was RAS wild type, BRAF wild type. The patient received FOLFIRI and cetuximab for her first-line treatment. She had an initial response followed by disease progression. The patient has an ECOG performance status of 1 now. She received FOLFOX and bevacizumab as second-line therapy. The patient developed progressive disease. Now that this patient has progressed on first and second-line chemotherapy, we have to consider a third-line option. The options of treatment for a patient who has progressed on irinotecan, oxaliplatin, and fluoropyrimidine, as well as anti-EGFR therapy in the setting of a RAS wild-type tumor, is either regorafenib as monotherapy or TAS-102, which is trifluridine and tipiracil. Obviously, our goals at this point is to continue to improve the overall survival of our patient, but also an important goal in the management of patients with metastatic colorectal cancer is to improve their functionality and to diminish the chances of worsening in performance status and decrease their symptomatology. This is an appropriate patient for TAS-102 monotherapy. The reason for such is that the patient has a good performance status and she has progressed on first and second line treatment and she has no further option of cytotoxic chemotherapy. This would be an ideal candidate for TAS-102.